All right. Good morning. My name is Bailey Nagy. I am a senior here at Simpson College. Please excuse any background images or noises as I am at nannying at this very moment. It was really my only time to do this video, so my nanny kids are in the back. So let's just get started. I'm going to share my screen with my presentation. And then move my face out of the way. See if I can get me up in this corner as high as possible. Okay, so for my presentation, I did muscular dystrophy. Muscular dystrophy is a broad name for a category of genetic disorders that affect, obviously, the muscles. The main goal of this presentation was to kind of go over the various forms of MD and then what type of rehab there is available or what type of therapy is really available. Just to start out, let's do an overview. As I had mentioned, MD is a broad category for a name of a group of inherited genetic conditions that progressively cause the muscles to weaken. The causes of MD, so typically you'll see it be inherited, an inherited faulty gene from one or both parents, spontaneous gene mutation or an alteration in genes. We'll get into what that specific gene is later. And then overall, hold on, let me make sure I am. Okay, sorry, I was just double checking that I was in fact recording. And then as I had said, it affects overall, obviously there are very many different forms, but for the forms that I'm going to go over today, they're typically affecting the cardiac muscle, the respiratory muscles, the calves, thighs, throat, eye muscles, hips, arms, all of our muscular groups. So we're going to dive in a little bit more to the various types of them. So Duchenne's MD is the one that I am most familiar with, and I have actually been able to work with an individual with Duchenne's MD. This is the most common and the most severe form. It typically presents itself within boys and early childhood. It's not only subjective to just boys, but it is typically seen in the male population. The second one is Becker MD. This is the muscular dystrophy that is most closely related to Duchenne's. It is also the second most common, but it is much less severe and it develops later in childhood. From the cases that I've seen so far, Duchenne's progresses the quickest and life expectancy is the shortest. Myotonic dystrophy, this can develop at any age and will affect life expectancy if it is severe enough. Limb-girdle will develop in late childhood or early adulthood. There's two different types, and it typically progresses slower compared to Duchenne's. And then the last one is facioscapulohumeral MD, which develops again in either childhood or adulthood. There's two different types, and it's not typically life-threatening, so to speak, as like the life expectancy. It does just affect, we'll get into that later, but it is not life-threatening. There are 7 forms of MD, but I decided just to dive in, just to give a quick definition on these. There are more, but these are the most common in terms of 1 through 5. So preventative therapy. So again, MD is due to a gene mutation or an inherited gene. So unless you do scanning of a child in like before it is born, you will not be able to prevent it. But what we can work on is kind of slowing the progression or slowing the pain. Obviously, most of this is not my scope of practice. I'm really just going to be diving into physical therapy, but I just want to touch base on a couple of them. So physical therapy, as I had mentioned, we're going to really try to prevent that muscle atrophying and decreasing the joint flexibility, because that is what you will run into with a lot of patients with MD. We have really weak muscles, really tight joints, not a lot of range of movement. So physical therapy is going to work on that. Respiratory therapy, as I had mentioned, the cardiac muscle and the respiratory muscles are affected by MD. So if we are able to prevent the loss of respiratory strength and the loss of cardiac muscle, we can prolong our health and try to shorten the period of ventilation. So with Duchenne's, children do end up on 24/7 ventilation. They start with just ventilation at night and move to 24/7 ventilation. What we're trying to do here is just slow that process and try to keep off ventilation as long as we can. Speech therapy, this is just because a lot of some of the facial structures and the face muscles are affected with having MD. So some of our individuals will have difficulty with speaking. So we're just trying to learn how to slow down the speech, work through that loss of muscle within our face and throat muscles, and then start to use communication equipment again. Not the scope that we're looking at in this class, but I just wanted to mention it. Another one, drug therapy, not the scope, but just wanted to mention it, and gene-based therapy. This is a little bit out of my knowledge. I've included exactly what they do. Does not mean I completely understand it, but I have included it. So what I'm going to do now is go over the 5 that I mentioned. The bullet points on the left are kind of a quick summary, but the pictures on the right will really dive into what we're seeing. So for Duchenne's, obviously this is the most common. This is a genetic disorder that progressively weakens the muscles and, like we mentioned, shortens the lifespan. The gene that I mentioned earlier, it's called the dystrophin protein. So this is what is responsible for keeping muscle cells intact. This is exactly what is being targeted and what is being mutated and what is restricted in our kids with muscle dystrophy. So Duchenne specifically will result in, they start with difficulty in walking, difficulty jumping, running, speaking, and then eventually, as I had said, 24/7 ventilation, and lifespan is only from teens to 30s. I think the oldest case that they've had was an individual in their 30s, but they have had children who have unfortunately passed in their early teens due to Duchenne's. So this picture on the right, the numbers on the left are just like big number categories of stuff. On the right is going to exactly like dive into what's happening to the muscles. So again, loss of muscle mass, inflammation, weakness, brittle. You can see where it's hitting the respiratory, a weakened diaphragm, pneumonia, ventilation, cardiomyopathy, heart failure, and then something that we may not see a lot talked about with MD is actually the cognitive and learning difficulties. The brain is a muscle too. So if you are experiencing weakness in the rest of the body, you can imagine you're going to experience some weakness in the brain, and that's going to lead to cognitive disabilities, social disabilities, even learning disabilities. So that is all that comes with Duchenne's, comes with a lot of the forms of MD. Becker MD, again, this was the second one. This is a slower process than Duchenne's, but fairly common as well. It does affect the lifespan, but not as early as Duchenne's was. So unlike Duchenne, individuals with Becker muscular dystrophy do have levels of dystrophin within them. It is just very depleted. So that affects their ability for their muscles to function normally. This will cause weakness of skeletal muscle, respiratory muscles, and cardiac muscles. Appears as early as age 5. Much slower progression, like I've mentioned. What you'll see is the hips and the pelvic area is targeted first. So we see individuals in wheelchairs a little bit earlier with Becker, and then cardiac weakness we have mentioned as well. Myotonic dystrophy, this one's a little bit different. So this has 2 different types. I'm not going to dive into those again because this is not my scope of practice, but DM1 and DM2, those are due to a defect in CMDP or the myotonic dystrophy protein kinase. Again, not what we're diving into, but just wanted to let you know as a watcher. This will cause weakness in our respiratory muscles, digestive muscles, and the cardiac muscles. So this image on the right will dive into all of the symptoms of myotonic dystrophy. This one is really different in the fact that we are going to see cataracts and pattern baldness. So that is something that you won't see in the other ones. This is really targeting the eye muscles, the heart problem, even digestive, which we didn't see in the 2 earlier ones. And then the skeletal muscle weakness, muscle atrophy, and the myotonia are all the same as the other 2. Limb girdles, this one is a little bit different again. So this is the one that has 2 different types as well, one that presents in adulthood and one that presents in early childhood. This limb girdle affects proximal muscles, so specifically the shoulder girdle and the pelvic girdle. This is very evident in individuals when they start learning to walk with a waddle gait. Limb girdle will eventually progress to the point where there is either a complete loss of walking ability or it's a very, very, very limited. They are often wheelchair bound, as most of our MD patients are. But depending on the age at which it presents itself, if limb girdle was to present itself in an individual like early childhood, someone that just started learning to walk, we may see them move on to the wheelchair earlier on, just because they are just learning how to walk and now it's been interrupted and they probably will be wheelchair bound quicker. If we are older and we are seeing this present in an individual that is within adulthood, they have already been walking for most of their life, we can PT, we can rehab, and we can prevent wheelchair walking early on or wheelchair usage early on. But either way, it's going to result in a loss of walking ability and probably wheelchair bound. Fascioscapulohumeral, MD. So this is exactly what it sounds like. This will affect the face muscle, the scapula, and the humerus. I included, this is the third most common form. Again, it has like adult onset and then infantile onset. Individuals, they call it FSHD, so for short. So individuals with FSHD experience a normal lifespan. Life expectancy is not affected, but I did want to include this picture on the right because it almost looks like I've stretched the image, and that's what I wanted it to because I have not. This is exactly how it presents. This is exactly what it looks like. You can see that individual, his scapula are poking back because there's truly not enough muscle back there to cover his bones. You can see his bones right through him. You can see his chest is depleted. You can see when he's standing that it just like is all one area. It just flows from his neck onto his shoulders. They're almost all the same size. They just experience a complete lack of muscle mass in their upper extremities. This really will affect activity. This will affect being able to partake in something that requires like contact sports. Can't do that because they're not able to either move quick enough to hit the ball way out of their face, or they're just very, very weak, so to speak, because of just that complete loss of muscle mass. So for our overall goals with patients with MD, I've talked a lot about life expectancy and what that looks like. I want to say a reminder, and this is what the first bullet point is going to be. MD patients typically, because the most common ones, present with a shorter lifespan than the average individual. So if we are working with a patient with a very short lifespan, I'm not going to put them through rigorous rehab and therapy because at the end of the day, they're going to lose muscle mass. They're going to be on a ventilator. That's not my goal. Our goal is to keep them happy and comfortable as long as we can. So my very first goal with my patients is quality of life. The second one, what we want to do is try to prevent muscle weakness and atrophy as much as we can, just by getting those muscles moved in any way that we can. And then lastly, kind of cut this off, but rehab of our already weakened muscles. So depending on when we get the patient, I know of one of our kids with MD was not brought to us until he was 6. And he had gotten his diagnosis when he was, I want to say 1.5, 2. So a year gap between coming to a place where he partakes in physical activity. So you wonder what he was doing in that gap. And if he was not doing rehab or he was not doing therapy or activity of some sort, his muscles are already weakened. So what we want to do is try to rehab what we've already lost. So I picked a few specific symptoms that come along with each form of MD. Obviously, in my scope of practice, will not be looking at the cardiac muscles or the respiratory muscles. I'm not really even like joints or like that, so to speak. I'm really just doing more activity. So I kind of wanted to gather what I've seen works with my kids, what I can make into an activity, and then what I've seen my kids use. So there's something called contractures. There's pictures on the bottom, and I'll explain each one. But the picture on the left, this is an older individual, but as you can see, their muscles have tightened, the tendons will tighten, their skin and the tissues will shorten and become extremely stiff. So a lot of our patients with MD, you'll see their hands are always stuck in this position. Maybe their neck is stuck. Maybe their arms are tucked into their sides. They're just very stiff and rigid. Wherever you're stiff and rigid, those adjoining muscles and tendons will also become tighter. So even if you're experiencing just tightness in your hand, you can imagine then you pinch your arm to your side. I'll move this down so you can get a better image. You pinch your arm to your side, this is going to become tight and stiff. So eventually, if you're tightening just your hands, we're going to move into the wrist, we're going to move up the arm and into the shoulders. So what I try to do is I try to use resistance bands with my patients, try to just, and this is all passive, I don't have them doing it. Obviously, you can't pull on something if you can't grab it with your hands. Again, that's not the point. The point is quality. So I will let them do, I do a lot of hand work with like foam balls, just trying to get like that feeling of grabbing something. And then I will use resistance bands to kind of pull those muscles. So here that she's just doing it on her calf, as you can tell, moving her foot back and forth, pulling that resistance band, getting some stretch in there. And then this picture on the far right, this is something that I've seen a couple of my patients use. It's typically my adults. My kids aren't using these yet. But in my adults, this is just that that little hand fitting. I don't know the exact name for it, but it is to keep their hand from essentially shriveling up during the day. So we're trying to keep that as stretched as possible and try to prevent that tightening of our hand muscles. Toe walking. So this is what we'll see in our kiddos when they first start walking. Not every kid that has, or not every individual that starts toe walking has MD, but this is what you see a lot in kids with MD. And this is because their calves are so tight, or there's just a loss of muscle mass there. So toe walking is when a child consistently walks on the balls of their feet and keeps their heels off the ground. It is not helpful to wear, like, typically when I have someone that is toe walking and doesn't have MD, I'll use like ankle weights to really keep their feet down, keep those heels on the ground. With our patients with MD, that's not really necessary, mainly because it's not due to the fact that they don't want to walk on their balls of their feet. Or the walk with their heels on the ground. It's because they can't. So I don't find that ankle weights are necessary. What I like to do is just deep tissue massaging. This picture on the left shows deep tissue massage in the calf. I think that's very important because that's where most of our tightness comes, and that's why our kids are walking on their toes, is because their calves are so tight, or they have no strength in their calves. And then, so that's what I would do with our younger kids. Looking at an older individual, an individual that has already been walking for some time and now has started toe walking because of the tightness in their calves from developing adulthood MD, I would try the sit and stand test because that really focuses on using the balls or using the heels and pressing into the heels to stand up and sit down. It's very simple. It's very plain. It's very boring. But again, we're looking at quality of life. We're not trying to do intense physical rehab because at the end of the day, it's not helpful. And they also can't partake in intense physical rehab due to decreased cardiac function and decreased respiratory function. Head lag. So this is what we'll see in our babies. So early infantile developed MD. This is when the head will sit behind the neck due to poor head and neck control. So really what that looks like is their head is just going to be lagged back or tilted back a lot. Because of that, the shoulders will elevate and stick. So this one's hard. Again, I'm not a physical therapist, but with a lot of my kids that come in, they don't, so to speak, have to have a head lag, but it's just poor head and neck control. Those shoulders are tight. What I try to do is whenever we're playing a game or whenever we're partaking in activity and I see them just kind of tightening up, I like to just come over and just hold this down. I like to have them put sometimes like a noodle around their neck. So the noodle will sit about here. If my shoulders are elevated, my noodle is hitting the bottom of my ears. So what we try to do is have our kids wear noodles on their neck and try to have them not stick those head up. They feel the noodle on their neck, they know their shoulders are elevated and they need to put those down. So just having like persistent pressure or something there to remind them. When kids are younger, I did find an article on 2 different things. So having your child help find their equilibrium, helping where they can find, where they keep and have good head and neck control, and then kind of moving them around until they lose it, returning them back to that position where there's equilibrium and starting again. And then a reverse pull to sit is really just when you have the patient, or here in this case, the infant in front of you. They are seated on the floor, you are seated on the floor, but they're facing you, holding onto their shoulders and pulling them back lower to the ground. Once they lose that neck control, pull them back up, help them hold that neck. And once they get to that place, try to slowly release and see if they can hold it any farther down. This is not exactly my scope, but I did find an article on how this is helpful. I do this with my kids that have weak cores, just trying to kind of help them realize that they're not pulling up with their neck because they're supposed to be using their core. If they're not using their core, it's because they have a weak core. So just assisting with that neck, holding and coming up and down for those sit-ups. Overall muscle weakness. So this is what every patient with MD will face, whether it's in the face, whether it's in the calves, whether it's in the hands, we're seeing overall muscle weakness. So as this red bullet point here says, not only are muscles weakened, but some of them are completely non-functioning. Some of them are stiff and they will not move. Sometimes we'll get kids that already have non-functioning muscles. They have already passed that point. They've lost the prevention and we are fully just in rehab or just slow movements. So what the first two pictures are kind of trying to show you is that most of what we will do on their muscles is passive. So passive stretching, passive range of motion, passive movement, because they are not strong enough to move it themselves. So most of it's going to be passive rather than them doing it themselves because they're purely not able. Some of them are wheelchair bound, so I will just be moving the legs for them. And then this last point here, this is E-stim. I did read an article on how this was helpful because most of our patients with MD don't have function within some muscles. So those muscles are not being worked. So those muscles are not being used. They don't know what it feels like to move and work. So using E-stim to just kind of contract those muscles and remind those muscles of what it feels like to move and get the blood flowing. At the end of the day, it's not going to get them movement back. At the end of the day, they may not feel it, it may not help, but to the body itself, just knowing and feeling what it feels like for those muscles to move, I think is helpful. So the last point here, the main overarching theme that I've had with muscular dystrophy is that we are really here to improve the quality of life. I am not here to have them sprint, have them doing crunches, have them doing wall sits, and trying to strengthen those muscles because sometimes they present us with a complete lack of muscle. They've already lost it, it's non-functioning, there's no rehabbing it, it's just done. So we really just want to get them in any kind of activity that we can, any type of movement we can that they enjoy, and that purely just gets their heart pumping and their lungs working. So quality of life is what's most important here with our patients with MD. Whether or not their life expectancy is shortened, it doesn't make the quality of life any less important. I just don't believe in hard rehab and intense rehab with our patients because we are not going to be able to stop the progression. We can slow it down, but we will not stop it. At some point, it will happen. At some point, they will need a ventilator 24/7 or they will be wheelchair bound. So really just trying our best to make them the most comfortable as they can, doing small stretches, doing small work with the hands just to remind them what it feels like, E-stim to remind them what it feels like, just to get the blood flowing, even if they are not able to do it themselves. So end of the day, quality of life is what's most important. And then these are the resources for all of the images that I have shown. My AMA paper is attached in a different link on this presentation. So you will have access to that, and that will give you access to all the articles and such that I used in the paper. So yeah, thank you for watching.